This video demonstrates how to use the Avanos Mix Safety Pull and Push Peg. Prep and sedate the patient for an endoscopic procedure. Insufflate the stomach with air and transilluminate the abdominal wall. Select the gastrostomy site. Prep and drape the skin at the selected insertion site. Locally anesthetize the insertion site. Following local anesthesia, make an approximately 1 centimeter incision through the skin with a safety scalpel. Insert the introducer safety needle system through the incision, advancing through the peritoneum and the stomach wall. When the introducer safety needle is observed in the stomach, remove the introducer needle from the introducer cannula by firmly holding the pink safety locking collar and pulling back on the needle hub. To activate the introducer needle's safety mechanism, advance the pink safety locking collar to the end of the needle tip. Note, the safety locking collar will lock in place permanently. Insert the retrieval snare into the endoscope and push the retrieval snare through the endoscope until it is observed in the stomach. Place the looped placement wire through the introducer cannula into the stomach. Grasp the looped placement wire with the retrieval snare. Withdraw the retrieval snare into the endoscope channel. Remove the endoscope and the looped placement wire through the oropharynx. Slowly and smoothly feed the looped placement wire into the introducer cannula as the endoscope is retracted. Pull approximately 5 inches or 13 centimeters of the looped placement wire from the mouth. Keep the introducer cannula in place in the stomach with the distal end of the placement loop outside the abdomen. Connect the looped placement wire with the tube loop. Lubricate the MIC-PEG tube with a water-soluble lubricant. Apply traction to pull the placement loop and the tube back through the oropharynx and the esophagus and into the stomach. Re-enter the esophagus with the endoscope and visually follow the gastrostomy tube as it enters the stomach. Slide the introducer cannula out of the incision site and gently pull the PEG dilator tip through the abdominal wall. Use a rotating motion to slowly work the tube up and out until the internal bumper gently rests against the gastric mucosa. Note, graduated markings on the body of the tube will assist in determining the progress of the tube as it exits the abdomen. Caution: do not use excessive force to pull the tube into place. This could harm the patient and damage the tube. Cleanse the tube and the stoma site and apply a sterile gauze dressing. Cut the tube loop wire with scissors and discard the tube loop and placement wire. Slide the external bolster over the proximal end of the MIC-PEG tube and push the external bolster into place next to the sterile gauze dressing. Visually verify that the internal bumper is properly placed. The external bolster should be positioned approximately 2 millimeters above the skin. Caution: do not apply excessive tension. There should be no compression of the gastric mucosa or the skin. Optionally, a suture loop, not supplied, may be tied around the external bolster to minimize movement of the MIC-PEG tube while the stoma is healing. Cut the MIC-PEG tube at approximately 90 degrees, leaving an appropriate length to attach a MIC feeding adapter on the proximal end of the MIC-PEG tube. This adapter will accept a catheter-tip syringe or a standard feeding connector. Discard the removed portion of the tubing. Procedural steps for the push technique are the same as the pull technique until the guide wire is being pulled from the mouth. At this point, complete the following steps. Remove the endoscope and the guide wire through the oropharynx. Pull approximately 45 inches or 114 centimeters of the guide wire from the mouth. Before advancing the MIC-PEG tube into the oropharynx, feed the tapered end of the MIC-PEG tube over the guide wire until the wire exits the opposite end of the MIC-PEG tube. Once the guide wire is approximately 45 inches or 114 centimeters from the mouth, slide the introducer cannula out of the incision site. Lubricate the MIC-PEG tube with a water-soluble lubricant. Keep the guide wire taut and push the MIC-PEG tube in an antegrade method until the tapered tip of the tube dilates the stoma tract through the abdominal wall. Re-enter the esophagus with the endoscope and visually follow the gastrostomy tube as it enters the stomach. Grasp the tapered tip of the MIC-PEG tube as it penetrates the abdominal wall and pull the PEG tube so that the internal bumper moves into the stomach and remove the guide wire. Use a rotating motion to slowly work the tube up and out until the internal bumper gently rests against the gastric mucosa. Note: graduated markings on the body of the tube will assist in determining the progress of the tube as it exits the abdomen. Caution: do not use excessive force to pull the tube into place. This could harm the patient and damage the tube. Procedural steps to secure the PEG are the same as the pull technique referenced earlier. Keep the skin around the MIC-PEG tube stoma site clean, dry, and free of drainage. After the stoma is healed, a dressing is not necessary with the MIC-PEG tube and may even cause moisture retention resulting in skin irritation. The MIC-PEG tube should be removed by either traction removal through the stoma or through endoscopic retrieval. Caution: it is not recommended that a portion of the tube be cut to allow the internal bumper to pass. When the 14 French PEG is used, use the endoscopic removal method only. Warning: never attempt to change the tube unless trained by the physician or other healthcare provider. When the physician determines that the tract is formed, usually within 4 to 6 weeks after placement of the PEG, the MIC-PEG tube may be replaced with an alternative feeding device. We recommend using one of the following: the Mickey low-profile gastrostomy tube or the MIC gastrostomy tube. Ensure this type of tube can be replaced at the bedside. To remove the tube, prep the patient for the MIC-PEG tube removal using standard procedure. Lubricate the skin and tube around the stoma with a water-soluble lubricant. Rotate the tube 360 degrees and move the tube in and out slightly. Warning: if the tube does not move without restriction in the tract, do not attempt to use traction as a method of removal. Feeding tubes that have been in place for several months may have an increased potential for internal bumper separation during traction removal. Caution: when the 14 French PEG is used, use the endoscopic removal method only. Position one hand on the abdomen around the stoma with the thumb and forefinger approximately 2 inches apart to stabilize the abdominal wall. Grasp the tube with the opposite hand next to the stoma site. Firmly but gently pull the MIC-PEG tube until the internal bumper emerges through the stoma. Replace the MIC-PEG tube with the appropriately sized gastrostomy tube. If the tube cannot be removed with a reasonable amount of traction, it should be removed by endoscopic retrieval. The ENFit PEG is featured, but a non-ENFit PEG is available.